Bismillahirrahmanirrahim. Today's our question. A 30 years old woman delivered spontaneously 20 minutes ago after 16 hours labor. She was given 10 units of oxytocin intravenously immediately after the birth and was delivered of her placenta 3 minutes later. She has since lost 750 ml of blood vaginally. After rubbing up the uterine fundus manually, which one of the following is the most appropriate next step in the management? Option A is inspect the placenta, inspect the vagina and cervix for lacerations, empty the bladder, cross match blood, give ergometrine intravenously. Inspect the placenta, inspect the vagina and cervix for laceration, empty the bladder, cross match blood, give ergometrine intravenously. So these are the options. Answer is ergometrine we have to administer. All of these responses need to be done, but the most important immediate next step is to ensure the uterus is contracted by administering ergometrine. Ergometrine should achieve a profound uterine contraction after the uterus has been rubbed up manually in an attempt to expel any intrauterine clot, which would consume clotting factors and allow further bleeding because of inadequate uterine contraction. Having administered the ergometrine, the placenta must be inspected for completeness, the vagina and cervix inspected for laceration, and blood sent for cross-matching, and the bladder emptied by catheterization to ensure the capacity for uterine contraction is not inhibited. A check is also needed to ensure the blood being passed was clotting. If the bleeding continued despite these measures or the placenta appeared incomplete, uterine exploration would be required. So here option E is correct, which is ergometrine administration. Our next question is 52-year-old man presents at the clinic seeking advice on a screening for carcinoma of the large bowel. He has a no gastrointestinal symptoms. His younger brother has developed a colon cancer at the age of 50 years. He has a no other family history. Which one of the following is the most appropriate advice to give to him about current and future management? 52 years old man presented at the clinic seeking advice on a screening for carcinoma as his brother had CA colon at the age of 50 years. Option A is no screening procedure is required at this time. He should undergo fecal occult blood now. Colonoscopy should be performed now, and if clear, no further screening is required. Colonoscopy should be performed now and at 5 yearly intervals thereafter. Our last option is colonoscopy should be performed now and yearly thereafter. The NHMRC guidelines, this is the National Health Medical Research Council, this is Australian Government Authority Council. NHMRC guideline published in 2008 make the following recommendations. The asymptomatic patient over the age of 50 who does not have any risk factors for colorectal cancer should be offered annual fecal or occult blood test or sphygmomydoscopy, either flexible or rigid. In any patient over the age of 40 with lower digestive tract symptoms, the diagnosis of colorectal cancer should be considered and investigated appropriately. The appropriate investigation for recent onset of symptoms would be a colonoscopy. For those at slightly above average risk, no personal history or with a first or second degree relative with colorectal cancer diagnosed at age 55 or older, described as a category 2 risk, there is a 3 to 6 fold increased risk of developing colorectal cancer. The recommendations are for annual FOBT from the age of 50 or 10 years earlier than the family's youngest affected individual. In addition, a flexible sigmoidoscopy every 5 years from the age of 50 should be considered. For those individuals considered at a moderately increased risk, one first degree relative with colorectal cancer diagnosed before the age of 55 or two first or second degree relatives on the same family side with colorectal cancer, it is recommended that they have 5 yearly colonoscopies starting at the age of 50 and annual FOBT in the intervening years. For those who are members of families with familial FAP, familial adenomatous polyposis, or HNPCC, hereditary non-polyposis colorectal cancer, careful screening and surveillance is required. Screening of at-risk members of HNPCC families should be an annual or biennial colonoscopy commencing at the age of 25 years. At a risk individual in FAP families required annual sigmoidoscopy from the age of 10 years and then every 3 years from the age of 35. This patient's risk is above average, moderately increased risk, and he should be advised to have a colonoscopy now and at 5 yearly intervals thereafter. Annual FOBT in the intervening years would be appropriate. Means in between 5 years, annually we can suggest for the FOBT also. A 55-year-old dye factory worker presented with painless hematuria and a computed tomography with contrast showed a filling defect arising from the renal pelvis, suggestive of a urothelial tumor. Which one of the following is the most appropriate treatment? 55-year-old dye factory worker presented with painless hematuria. CT scan with contrast showed a filling defect arising from the renal pelvis, suggestive of urothelial tumor. So which of the following the most appropriate treatment? How you will treat? Nephrectomy, you will remove the kidney. Nephrectomy, open fulguration, cytotoxic drugs, nephroureterectomy, external radiation therapy. Nephrectomy, open fulguration, cytotoxic drugs, nephroureterectomy, external radiation therapy. Here correct option is D, which is nephroureterectomy.